Well, good afternoon. My name is Rachel Stockton. I am Chief of Staff here at the Surgical Data Science Collective. Absolutely delighted to welcome Dr. Jeffrey Lin to this afternoon's Data Science Roundtable. We're so thrilled to have him here, and I'm really excited about this afternoon's talk. Let me take a moment to do a quick introduction to share some information about Jeff. Dr. Jeffrey Lin is the Director of Gynecologic Oncology at Sibley Memorial Hospital and a board-certified gynecologic oncologist with more than 4 decades of clinical experience spanning women's health, oncology, and minimally invasive surgery. He earned his medical degree from Albany Medical College, completed his residency in obstetrics and gynecology at the George Washington University, and completed fellowship training at the Gynecologic Oncology at the University of Rochester Medical Center. Dr. Lin is a member of the American College of Obstetricians and Gynecologists, the Society of Gynecologic Oncology, and the American Association of Gynecologic Laparoscopists. I think I might have said that wrong. Forgive me, Jeff. Throughout
It's
his
perfectly
career,
fine.
he has been deeply committed to advancing surgical quality, education, and patient outcomes in gynecologic oncology. As one of SDSC's newest clinical advisors, Dr. Lin provides guidance on medical, surgical, and operating room excellence, with a particular focus on analysing OBGYN surgical video and expanding SDSC's research and innovation efforts within this domain. His perspective brings critical clinical insight to the application of data science and AI in women's health surgery, helping ensure that emerging technologies are grounded in real-world surgical practice. Jeff, we're absolutely delighted to have you here today. Over to you.
Well, thank you, Rachel. It's been a real pleasure. I can genuinely say that in this last month that I've had a time to meet many of the members of the SDSC team. I have almost 35 years of experience doing complex gynecologic surgery. I was first at George Washington University for about 15 years, and I was the chief surgeon there. And then I moved to Sibley Memorial Hospital, Johns Hopkins in DC for the next 19 years. And actually, I'm going to be starting in February at Georgetown University Hospital, practicing surgery there. And so, when Dan first approached me about SDSC, the surgical video platform, it was very intriguing. I'm a very traditional person. I love doing surgery. I've done probably more than 10,000 surgical cases in my career. I spent a lot of time in the hospital, but I'm very intrigued by what this new world of AI and machine learning and video analysis can bring to even an old surgeon like myself. And so, as we began to talk, and he shared with me his experiences in neurosurgery, I certainly could see how some of this could impact the way we do gynecologic surgery. And so let's just see if we can go down. So I put together a few slides, not to teach you everything about gynecologic surgery, but just to sort of intrigue you, titillate your interest in it, and maybe get your ideas, which I would value greatly, about things that AI and machine learning could contribute to gynecologic surgery. So we could talk a little bit about the scope of gynecologic surgery, for what kinds of diseases and conditions we do surgery, what's the volume of surgery, how we do the surgery. And then I plan to talk a little bit about the ones that are video-based, which is obviously why we're here. And then these are primarily minimally invasive gynecologic surgery, but I also have an idea of maybe expanding this to doing more traditional open surgery, which we'll talk about later. And then I want to sort of touch on how the surgical video platform can potentially help us do gynecologic surgery better. And again, I think it's sort of an open-ended question about, what can be accomplished. And that's part of the excitement of it, because we just don't really know where this will lead. And then I can tell you a little bit about what I view, and again, it's just my opinion, of what the challenges could be in gynecologic surgery as, let's say, compared to neurosurgery, which you have already a substantial library of. So, Just to give you an idea about the scope of gynecologic surgery, so probably the most common surgical procedure in the world is a cesarean section. I've done probably more than 1,000, most of them very early in my career, actually maybe several thousand. And you don't even think about it. Sometimes I remember doing some in like 12 minutes, and so, but at the same time, it's a real invasive procedure. And, to give you an idea, in the world, there are about 38 million cesarean sections performed annually. So even in the US, there's about 1.6 million. So clearly, this is the most common surgical procedure being performed. Now, again, cesarean section is performed through an incision in the lower abdomen. It's not done in any way by laparoscopy or robotic surgery. So it's probably not a surgical condition or surgical procedure rather that we would be focused on. The other very common procedure would be surgery for uterine fibroids or uterine leiomyomata. So this is a wide range of different kinds of surgical procedures. Some of them are performed through the cervix and the vagina into the uterine cavity, and this is done by hysteroscopy with an endoscope. This is not probably the area that we'll be looking at first, but that's something where the fibroids are partially resected to improve the symptoms caused by fibroids. And these symptoms typically include heavy menstrual bleeding, irregular menstrual bleeding. Sometimes it's so heavy that patients become anemic and need to be transfused, pelvic pain, and sometimes obstruction of adjacent structures, like compression of the bladder, less commonly bowel obstruction, and frequently some interference with childbearing. So it could be, in some cases, recurrent miscarriages, infertility, things of that sort. And so this is probably one of the most common diseases that leads to having surgery in women. And so there are two types of surgery for fibroids. One would be a hysterectomy, where the uterus and the fibroids are removed completely. And that's a very definitive procedure, but obviously does not allow for further childbearing. Another procedure would be a myomectomy, where the fibroids are removed from the uterus. You can see in this cartoon the fibroids within the uterine wall here. And then all these fibroids are extracted, and then the uterus is repaired after that. Now, both the myomectomy and the hysterectomy can be done through abdominal incision, which is called a laparotomy, or they can be done more recently by either regular laparoscopy or robotic laparoscopy. And probably currently, of the abdominal myomectomies that are done, for instance, probably about 25 to 30%, maybe even a little bit more than that, are done with the minimally invasive technique. And again, why one surgeon might pick one or the other, it depends on their surgical background and their philosophy. So, for instance, if there are a lot of fibroids to be removed, again, some people want to remove them all. That includes myself, versus others that just want to remove it more strategically, just removing the significant ones. The issue is that if you don't remove them completely, then obviously the risk of the fibroids growing and coming back is going to be much higher, and the symptom relief might not be as complete. But in general, if there's a lot of fibroids, I prefer just doing it through an incision. It's very efficient, and we have this enhanced recovery after surgery protocols, which allow patients to recover very fast and often stay in the hospital just one night after having an incision. But the minimally invasive surgery, and I'll talk more about that, does have a variety of common types of benefits, and they generally include faster recovery and less pain. And so a lot of myomectomies can be done like that. But the main issue is really the repair of the uterus should be very sound, because you don't want the uterus to rupture when the patient becomes pregnant later on. And then we have diseases of the tube and ovary. And so there can be a variety of them that might lead to surgery. There can be ovarian cysts or tumors, ectopic pregnancy in the fallopian tubes, infection with an abscess. And those are pretty common procedures. Most of those are probably done with regular laparoscopy, not so much robotic laparoscopy, but the platforms are very similar, and we'll talk about that later. And then there's what I do a lot of, which is really cancers that arise out of the tube or the ovary and the uterus primarily. And these are cancers of the female reproductive tract, and almost all of them require some surgical treatment as actually often the primary mode of therapy. Now, some of these are done laparoscopically, like uterine cancer very commonly, but with ovarian cancer, although some people do laparoscopy, especially for early disease, the disease is often very advanced, and so doing laparoscopy or robotic laparoscopy for that is less common, although some people are quite good and do that frequently. And then another common area of benign disease would be endometriosis. And again, endometriosis is when the endometrium, which is the lining of the uterus that evolves during the menstrual cycle and ends up bleeding, ends up in areas outside of the uterine cavity. So it could be on the surface of the uterus, the posterior pelvis, the sides of the pelvis, on the ovary, and sometimes in even very distant locations. And this is a disease that is often treated with surgical excision as the primary treatment. And again, this would be a disease that would be very suitable to be done in a minimally invasive technique, and even very advanced excisions removing parts of the bowel or the bladder or the sides of the pelvis, the lining, can be done with a minimally invasive technique. And this obviously would be kind of good case to go into the SVP library. And then there are procedures that are designed to treat pelvic floor relaxation, which generally is a result of childbearing. And this is what sometimes people call pelvic floor prolapse, and often is accompanied with various forms of incontinence, most commonly urinary incontinence, where a woman loses control of the urine, but sometimes also rectal incontinence as well. And the prolapse itself can be very unpleasant and impact quality of life. So these are the common, I'm sure I've missed some things, but these are the broad groups of GYN and surgical procedures. And most of the pelvic floor relaxations has to do with diseases or problems with the pelvic floor where the muscles are that have been damaged, both the muscle and the connective tissue and the neurological connections by having children. So with gynecologic surgery, traditionally we have a variety of different ways of doing it. So the way that was actually probably one of the earliest ways, and it's because it's one of the least traumatic ways, is doing things through the vagina or through the perineum. So typically the woman would be in stirrups, so the bottom would be exposed, and the surgery can be done through the vagina or through the perineum. This actually allowed for access to the lower part of the pelvis very well, and could be done even with a conduction anesthesia, like a spinal or epidural anesthetic, so the patient wouldn't have to be fully asleep, and generally carried a very low infection and complication rate. Now, the problem is that you're working through a narrow space rather, and you can't really see the upper pelvis or the abdomen. And so this is limited to certain kinds of procedures. So typically things which don't have a lot of pathology, and often things that have pelvic floor weakness, which gives you more visibility, are done through the vagina. But nowadays, this is much less common. And in fact, trainees that graduate residency programs in the US generally are not very good at doing vaginal surgery, because largely that's been replaced by doing laparoscopic or robotic laparoscopic surgery. So that obviously is done through small incisions, and we have specialized instruments and high-level camera. The main difference between the straight stick or regular laparoscopy is that even though it's a high-resolution 4K monitor and very advanced camera, it's still a flat screen, so we don't have the typical stereoscopic vision, which you would get with a robot, which obviously in the robot, the surgeon inserts their head there, and they're able to look through two eye channels. So you still have this stereoscopic perception that we have. when we're walking around. And so you actually have much better 3D visualization, depth perception, things like that. And so that's one advantage with the robotic laparoscopy over the straight stick. And then the other major advantage is that the instruments for the robot typically have 7 degrees of freedom. So they articulate like your hand, fingers, and wrist. So this allows for much more dexterous surgical dissection. But with straight stick laparoscopy, because people have been doing it for a long time, and some surgeons are, really superb. Pretty much, if you're a good enough surgeon, I've seen people do the same kind of surgery with the regular laparoscopy as compared to the best robotic laparoscopic surgeon. So it really depends on the surgeon. But in general, the learning curve for doing very complicated traditional laparoscopy is much longer and protracted than with robotic laparoscopy. Now, with this category, the transabdominal open surgery, this is done through an incision. Now, this is a vertical midline incision, but sometimes we make often a transverse lower abdominal incision here, which is where most C-sections are done. And this is great because you can see well, and you can take out large pathology through the incision. It's very efficient, and you can do a wide variety of surgery. And so, for cancer surgery, a lot of times when the cancer is very advanced, I'll do surgery through this mode. It does require a much longer time for recovery, but we do have, as I mentioned before, enhanced recovery pathways, which with proper medication, using local anesthetics, and a variety of other measures allow for enhanced recovery. So the hospital stay is much shorter than it used to be when I first started my training. So it's been cut down to probably about a third or a quarter as long as when I started. And the amount of pain and discomfort that patients have is much, much less. The main advantage of this is that when there's really terrible disease or terrible anatomic distortion, this is very versatile because you can really stretch the tissue, keep it on tension, keep it with this traction to show the planes much better to be able to do the dissection and separate everything to do the surgery safely. So for very complicated surgery, I still believe this is often the best route, although we can do very complicated, laparoscopic surgery as well. And then the last area is this vaginal natural orifice transluminal surgery. So this is a variation or sort of a hybridization of both the transvaginal surgery and the laparoscopic surgery. So basically, in this type of surgery, they use the vaginal orifice as the access point. So there's no incisions on the abdomen, not even small ones. And so by making a defect, usually starting in the back part of the top of the vagina, you can actually occlude the vagina and then put the laparoscopic or robotic instruments up through the vagina through this hole and do the surgery like you're doing a vaginal surgery, but it's just done with the small instruments. And you can fill the abdomen and pelvis with gas like we do for regular laparoscopy and robotic laparoscopy. So it keeps everything out of the way and you can see quite well. And then at the end of the surgery, the patient only has the closure inside the vagina. So there's no scar or anything on the external surface that you could see unless you put a speculum and looked in the vagina. So this is something that requires a different skill set because the perspective is very different. I have a friend at Baylor that's very famous for doing this, and he does a lot of very complicated surgery in this fashion. But this is something that, for the most part, is more of a much less common approach, but does hold a lot of promise. And again, this would be suitable for the video platform as well. So if we look at, broadly, what are the pros and cons of doing minimally invasive gynecologic surgery or MIGS? Clearly, and again, this is based on a lot of published studies. In most cases, there's less pain and probably less scarring, although that's harder to prove because you would have to look after the surgery is done to assess the level of scarring. But generally, the use of narcotics is much less, and there's usually a much shorter length of stay and return to function, return to work with minimally invasive surgery. Typically, there's less blood loss. And because you're using small incisions, there's a lower infection risk at the area of the incisions. One thing with, sorry, let me go back. One thing with laparoscopy is that you can move the laparoscope or with a robotic laparoscope closer or farther away, so you can actually get like a few inches away from where you're operating, so you have huge magnification. So sometimes that's useful, but sometimes it's not as useful because you have to be used to working at that kind of perspective, so you don't see the whole area. It's like just focusing on a very small part. So you might actually, other things might be happening, you might not pick it up because the field of view is so narrow. And for some procedures, quite a few procedures, for let's say if we're looking at hysterectomy where the uterus is removed sometimes for fibroids or for cancer, there's been a lot of comparative studies looking at doing laparoscopic hysterectomy, looking at doing it through an incision, doing with robotic laparoscopy. And they found out that in most cases, the outcomes are very similar in terms of accomplishing what you need to do and having the same complication rate of major complications. Another advantage of minimally invasive surgery would be there's an option for doing telesurgery. So, for instance, typically, obviously, when we're doing laparoscopy, I'm standing right next to the patient on the table because I have to handle the instruments and the assistant handles the camera. But with robotic laparoscopy, we could actually we have the console that the surgeon sits in the room, but it's 10, 15 feet away from the patient. And so in an extreme circumstance, the surgeon could be even in another state and be doing it if everybody placed the instruments and the trocars into the patient. And I could be doing this surgery in Montana. However, that does bring up a lot of issues because if there's an emergency and we need to convert, then I'm not there. I can't get there in time. But at least theoretically, that's something that's possible. And I think the military has tried that because sometimes they work in very remote areas. And there's also maybe potential for telesurgery in areas that don't have very many surgeons in, let's say, under-resourced areas of the world that somebody could help. But that's something that could be done, at least theoretically. So on the negative side for MIGS, it's less versatile, as I mentioned before, because we can't stretch the tissue as much. So if everything is melted together, it's probably not necessarily the best way to approach the problem. If we run into very heavy hemorrhage, somebody can use a suction device to suck the blood out of the field, but you're very dependent on being able to see things because you don't have the feel of things, and you can't evacuate the blood as effectively. A lot of times when we're working through an incision, we can put pressure on structures that are bleeding with a large sponge, and it can really shut down the bleeding very effectively. And it's hard to do that with laparoscopy. So you have to be very careful when you're doing the robotic laparoscopy or regular laparoscopy at keeping the field very clean. And if it gets submerged under blood, you're kind of in a very dangerous situation. And then the two approaches, doing it through an incision versus minimally invasively, they really are totally different techniques. The anatomy is similar, but you just need specialized education and training. And in general, since working through an incision is, most people are accustomed to doing things with their hands, it's very intuitive. But with laparoscopy and robotic laparoscopy, the learning curve is much, much steeper. And so getting back to the main reason for this talk is, how could SDSC help us gynecologic surgeons do surgery better? So there could be, with the SVP, we're going to maintain a large library of video-based procedures. So if somebody wanted to see me do a hysterectomy for early uterine cancer, they could watch that and access that very easily. So that's nice, and that's a way that people have been learning things over the last 10 years by watching surgical videos of other surgeons. But there are lots of formats for doing that, so this is not something unique to SDSC. Another area that could help would be in OBGYN training is 4 years in the United States after medical school. So in that period of time, a person would need to learn how to do office gynecology, learn how to do prenatal care, learn how to deliver babies, both vaginally and by cesarean section, and learn how to do gynecologic surgery, both open and laparoscopic surgery. So that's not a lot of time to learn how to do all these things. And so, unfortunately, for a variety of reasons, the residency has never been extended, even though the amount of material to learn now is about double than when I finished it 35 years ago. And so the typical graduate, especially with surgical procedures, doesn't have that many under their belt. And so, and then when they start practice as a young OBGYN, most of the time they're doing office practice or doing obstetrics. They're not have the older patient base that requires surgery. So they usually get very little surgery the first few years that they're out. And of course, when you've recently finished training, you're eager to get started. But if you don't have the patients to operate on, your skills deteriorate fairly rapidly. And so by having the SVP, it's certainly possible that once we develop analytics on surgical videos, that we could actually give the early practitioners feedback on the quality of their surgery and maybe give them some insights into how they could do things better. It's almost like having somebody looking over their shoulder and telling them what they could do better. And that could be incredibly useful to upgrade the level of surgical care, as well as provide confidence and satisfaction for the surgeons. And so that would be the providing the recent graduates. And again, this could also be done during residency training as well. So typically, when I was a resident, I'd work with other surgeons. Some of them had been practicing a long time. We'd work together. They would be basically mentoring me, showing me, explaining to me how to do things, giving me immediate feedback. But again, the number of cases we did was a lot more than they do now. And there were far fewer as far as the types of surgery. So I had a lot more repetition. And here, if we use the SVP platform to augment the regular mentorship training, then that could be very valuable. It's also possible that, we basically in OBGYN have a couple levels of certifications. So there's usually a written exam that we take, and then there's oral examination where you present a case list of the types of problems you had, both obstetric and gynecologic surgeries that you've done. And then an examiner will review the case list with you and ask you questions. But since a lot of surgery now is video-based, it seems to make sense that for credentialing for new providers and also for certification, that it might be better to analyze surgical videos as part of this evaluation process. And this definitely, I think most people would think would be a good thing, but it does require a lot of time. For instance, if I were to analyze, 20, people applying for certification and look at, 2 hours of video for each, that would be, consume a huge amount of my time, and I wouldn't be able to do a lot of other things. And so, but with AI and machine learning, it's possible that maybe this video review could be done in an automated fashion. And again, this is what area that's most exciting, which is that if we have enough videos uploaded and we get enough data and we do enough analysis of that, it may be that we can figure ways to do the surgery more effectively, more safely, and more efficiently. And this can all obviously be of value. And so even for somebody that has a lot of experience, that's done many thousands of surgeries, if you're open-minded, we should be receptive to having a critique done or suggestions done about our technique. And we may have blind spots and things that we weren't aware of that the machine learning could identify, which would be useful. And then as far as, there may be ways to integrate other visual data, let's say like preoperative imaging, into the platform, and maybe with the machine learning and analysis of the video, we could actually figure out how to do the surgical planning ahead of time better. And then when we know what we're going to do ahead of time better, then maybe the outcomes would be better. But it would be very interesting to see, as the system progresses, whether we could integrate other factors into it. It could be video images like MRI or CT scan, but there could be other things. It could be protein levels, biomarkers, other things could be integrated in it to help with decision making. So what are the challenges for the surgical video platform in gynecologic surgery? As you know, most of the library is composed of neurosurgical procedures. And so what makes gynecologic surgery different than neurosurgery? Well, typically, again, it's been a long time since I've watched neurosurgery, but based on my recollection, we work on a much wider surgical field than neurosurgery, which is focused often in a very small area. So, like, for instance, we work typically in the pelvis and mid-abdomen. In oncology, we work in the upper abdomen as well, and because the cancer is often spread there. And so we need to be able to see in all these different areas. And so the anatomy in each of these areas is very different. So if we're trying to maybe at some point look at how anatomy changes, because that's probably one of the most important factors in determining, whether you have a good or bad surgical outcome, whether you have high-risk surgery or low-risk surgery, as far as complications go, then being able to understand the anatomy is different. We don't just have one field. I'm looking at the center of the pelvis near where the uterus is. I'm looking at the sides of the pelvis where the ureter and the blood vessels and the lymph nodes are. And these are all different perspectives. And how do we take that into account? With regular laparoscopy and robotic laparoscopy, a lot of times we're looking at a lot of different angles of the tissue and the anatomy, and there's a lot of camera movement. There could be shifting the camera perspective during a 2-hour case 50 or 60 times, right? And then, as I explained earlier, there's a wide variation in surgeon level skills and surgeon volumes. And in gynecology, we have, the regular 4-year training, and then we have fellowship training after that. So for oncology, it's 3 or 4 years. For minimally invasive surgery, it's usually 2 years. And for pelvic floor reconstruction surgery, it's usually 2 years as well. And so clearly, and there have been many studies to substantiate this, the surgeon skill level varies a lot, but when you've been fellowship trained, usually the outcomes are much better and your skill level is much higher. And then, as I said, again, I don't know too much about neurosurgery, but I've seen very simple cases where the anatomy is pristine and normal, and cases where you can't really tell anything. It's like somebody just heated it all up and it melted it into a big molten mass. And, how do you deal with that kind of thing? Because that's really what makes surgery hard. And then the last thing, which is very interesting, which I'll talk about a little bit later, is, how do we get GYN surgeons to accept this? Because, part of this would be, they're very scared of losing their economic viability by limiting their surgical practice. So if you say, well, we're going to certify people for doing this, but, you're not certified, so you can't do this anymore, then that can affect them economically. So that's something to take into consideration. And then not so much in the US, but there may be equipment limitations in more difficult parts of the world in different medical settings. So this is, we sort of covered all these things, sorry. So if looking here, I'll just give you a little video, hopefully show up. So this is a video I had from very early on doing regular laparoscopy, looking at the abdomen. So you can see these little white spots are like implants of the ovarian cancer. And so we're basically doing an assessment of the entire abdominal cavity to determine, where the tumor is and how we should do the surgery, and whether we should do an extensive surgery or not. You can see here's the uterus and there's tumor there. But you can see with this rolling view that we're covering a lot of territory. There's an implant on the omentum, for instance. Here's the liver and the diaphragm area. So there's a lot of dynamic movement. We're looking 360 degrees around the abdomen. So this sort of shows that, the camera perspective changes quite a bit. So if we look at a little bit of data, this is looking at how surgeon training affects, outcomes. So looking at laparoscopic hysterectomy, primarily for benign disease, this comes from LA area. In a 5-year period of time, they looked at 728 laparoscopic hysterectomy. And you can see that the complication rate for people that are trained in MIGS, that have completed MIGS fellowship, and the general OB/GYN was quite different, and the serious complication rate was significantly different. It was 11% versus 18.5%. So this just shows that there's, people could be doing the same procedure, but the risks and their skill set is very, very different. And then I found this very interesting article from 2024 in Surgical Endoscopy that looked in the UK at the acceptance of surgical video recording. And there was an estimate that out of all the endoscopic GYN procedures in the UK, only about 20% of them were recorded. And this person tried to institute this video platform to collect surgical videos at a few academic medical centers in the UK, and they measured it for about 30 weeks, and they found that about half the videos got uploaded. And then they did a questionnaire. They looked at a lot of different things as far as how surgeons perceive the value of uploading videos and what were the obstacles and what their feelings were about AI. And they also looked at what the concerns of surgeons were, and they included like medical legal issues, of being sued, if the patients had access to the videos, how they might interpret them. And then, if patients ask questions about the videos, then the surgeon would have to take time to sort of explain things. And again, sometimes patients can be very obsessive about these things, and they basically come from a lay background. And so it requires a lot of education and time to educate them. And then things to do with their infrastructure and the costs. And then there are some concerns about, how anonymous are these internal pictures of patients' bodies, even though all the identifiers had been removed. And this was an issue brought up mostly by lawyers and industry representatives in terms of the confidentiality of all these things. So this is the table from that study that looked at a lot of different things. I don't know if I can make it bigger, but basically they looked at here's like artificial intelligence. They queried the surgeons about what they thought about it and how it could be used in the OR, then privacy concerns, and then the efficiency in terms of how much it costs to get it set up, and a variety of other things, whether this would actually improve quality, et cetera. And so, they identified, it was a very well done study that, even when you're trying to handhold people and guide them through it, it still takes a lot to get them to agree to use just to upload the video, and what we're proposing is even more complex than that. And then lastly, I just want to talk about pelvic adhesions. I think you've seen some pictures, maybe I showed you them earlier, what the normal uterus looks like. But here you can see, here's the bowel, and here's the part of the tube, and the ovary and tube are here, and the uterus is here, and the bladder is here. You can see this separation between the uterus and the ovaries and tube is totally obliterated, and the bowel stuck against it. That's unfortunately a very common thing, sometimes related to cancer or inflammation or infection, or if the patient's had a lot of prior surgery. And it can really be very difficult to identify it. Now, with the robotic laparoscopy or regular laparoscopy, because we can get in close, a lot of times we can sort of separate it. But a lot of it is done by feel, and this haptic feedback is negligible with the robot, and a little bit more with regular laparoscopy, but certainly not as good as when you're handling things with your fingers and hands. And so, again, there's some limitations about how endoscopic surgery can be applied to all cases. But anyway, at this point, I've done a lot of talking, so I'm happy to hear your comments and try to answer them to the best of my ability.
Lovely. Dr. Lin, thank you so much for that. That was fascinating.
Yeah.
Folks, we've got about 15 to 20 minutes or so for questions. So if you are keen to ask a question, just please either raise a hand or unmute yourself, and we'd love to hear them. Amy.
Hi, thank you so much for the presentation. That was really helpful and insightful, and I'm looking forward to reading the last publication that you referenced. I'm curious in terms of AI-based softwares. I know you spoke a lot about visualization, especially in the pelvic adhesion slide that you showed. But I'm wondering if, in terms of adopting this type of technology in surgery, is there anything that you would find helpful, whether it's improved visualization on the pre-op planning side? Curious to hear your thoughts on what you would want most next.
Sure. So I think one thing that's always struck me is because I've reviewed a lot of preoperative imaging. So I've reviewed a lot of CTs, MRIs, ultrasounds, et cetera. And, I think there are two things that sort of clue me in to if the case is going to be very hard or it's not going to be very hard. So one would be, the imaging. So sometimes you can see evidence that things are sort of blurred or smudged and everything is stuck together. The organs are not clearly defined. And that might clue you in to the fact that there could be a lot of distortion and adhesions. But actually, probably more importantly, is actually when you take a careful history from the patient and find out what they had done and who did it, because I always hate to operate on my own patients because I dissect things very thoroughly and it's always a mess. And sometimes I have to go back a third or fourth time to do something and it's never pleasant. And the other thing too is if they had complications afterwards. So for instance, if somebody had ovary and tube taken out, but they had a terrible infection afterwards, then you could be prepared. Or if they had Crohn's disease and had 5 bowel resections, and then it's not going to be pretty. But what I think would be really wonderful is if you know, we could come up with some analysis or a scoring system of when, we do the surgery, the video there, sort of analyzing, what the difficulty level would be and recognizing the distortions. And then if we pair it with outcome data, and then you could say, oh, if they have this kind of appearance, then, this is X risk for having a ureteral complication. And so it'd be really, but it may take a lot of data to get to that point. But that would be like something that I would aspire to, So
Thank you for
yeah,
that.
you're welcome. Again, this is something that I know is a work in progress. It's not something that will happen in 6 months or 12 months. It may take a number of years to get to the point where we really have something that's really useful to people. But I think that in terms of providing people feedback about some basic things, that's something that could happen fairly quickly. Like I know I talked to Dan before about the use of two instruments simultaneously. So you're using if we're doing robotic surgery, the right and left hand. And, to be honest, when you're doing surgery, you really need that because one hand needs to provide traction on the normal tissue, and the other is usually a cutting instrument or dissecting instrument. And so you see people that are recently trained, they're kind of simple. They can only use one hand at a time. But that's equivalent to my friends. He told me a long time ago, he always told people that, well, you can't eat a steak with just using one hand at a time. You need to hold one with a fork and one with a knife to be able to cut it. And you see people using just moving one hand at a time in the beginning, and it's clearly not a good technique. So, and that's something that the analytics could easily identify very fast. So
Dr. Lin, I've rather selfishly got a question.
sure,
I was really curious about that study that you referenced about the barriers to adoption of
right.
video and AI in the UK. I was curious whether, from your decades of experience, you've got an example of an equivalent technology that has met similar barriers of adoption, and if there has been, what were the things that um, facilitated its usage or a change in behavior from like the clinical community?
Well, I think the biggest one that comes to mind, and just your question is interesting, and I just been processing it. But I think the one I can think of and would be actually the start of using an electronic medical record. All right. So, that's been going on for how long now? 18 years or so. And that was a revolution in medicine, right? In the sense that, it required a long time to integrate it. And there's still a lot of issues with it. And physicians resisted it a lot in the beginning. And I clearly remember this. And, to be honest, the electronic medical record, has many values, but the main purpose that I can see is really it's good for ensuring proper compliance with things. So you don't want to get, accused of, HIPAA violations and, care violations and clawbacks and reimbursement. As far as communicating information to other providers and other doctors, it's probably not great because it tends to dump a huge amount of information of which you have to pick through to find the important stuff. And so it's actually much less efficient. I went from when I first started seeing in the course of a day, about, 36 patients. And then now like at 21, 22. And it's the same amount of time in the office. It's just that to complete the record, it just takes a lot longer. And there's still a lot of resistance. There was a lot of doctors that rather than to learn it or to continue using it, just retired and quit early, So it was really, now everyone kind of accepts it. And it's great for billing and things and pretty good for retrieval of information if you know how to use it. But it's just very time consuming. So that would be something that was much more than, accepting use of the SVP, I think would be. Now the SVP in the limited time that I've used it, I have noticed that it does take a lot of babysitting of the uploading of the video process. It's not something that happens in the span of 5 minutes, in most people's connections. And so that's something that, we've had to try to resolve because it's always the issue of time. I think, things that take more time, like it doesn't take any extra time if you get in the habit of plugging in a hard drive to the video device. That takes, 1 minute. But then to upload the video and stuff, it does take a lot more time. And so we had to figure a way to do that, I think, better.
Got it. Thank you.
Yeah.
I can see in the comments that Niraj, you've got a question, so I'll just mute myself. Thank you.
Yeah, hi.
Yeah,
I had a question about this in the context of LMIC countries, and I was wondering, like, I hear that I don't know if I'm pronouncing this right, but puerperal sepsis, basically sepsis as postpartum complications, is a big problem in many LMIC regions of the world.
right.
Is that something that, like, an AI/ML type application can help reduce?
Well, I think the puerperal sepsis is related to probably poor medical hygiene conditions in these parts of the world. So
Okay.
having gone to some of these obstetric hospitals in China and in India and Pakistan, it's pretty amazing how they do things. I mean, they have basically sometimes in these very poor places, just like a stainless steel container where they pour the IV fluid that goes into tubing that's reused and it goes
Oh
into
my
the
God.
IV, and the things are open air and all these crazy stuff like that. And
Okay.
I think actually puerperal sepsis is probably the most common cause of maternal death
Mm-hmm.
in these areas,
Mm-hmm.
which have a much higher maternal mortality than in the
Correct.
developed world. So, but I don't see the video being used that because that's just, I mean, you could make a video of, women going through labor and delivering a baby, and then I'm sure they can analyze it and they'd find, oh, they didn't wash their hands, oh, they didn't wear gloves, or they were, and all these things. And but
Mm-hmm.
again, I don't think that's kind of where we're at with that. I would like
Okay.
to do it. I didn't mention this, that I promised to. I was interested in exploring once we get things rolling of using a video recording on open procedures. So for instance, if I do 40 ovarian cancer debulkings a year, most of them will be done with through an incision, but I could easily affix a camera to my headlight, and then you would have a video recording of the surgery. And again, there's probably even more changes in perspective and movement there. But then, of course, usually I'm looking at what needs to be looked at because it's attached to my head. So, that could be something that we could explore as a video upload, and it'd be very interesting to see. I think in neurosurgery, there's still things that are also done, like craniotomies for like hemorrhage and this and that are not done with a microscope. So maybe it could also be applied to neurosurgery too.
Thanks.
Okay. Well, it was a real pleasure to talk to you and share some of my thoughts. I have a lot more, but I think this is a good start, and really just trying to, get more collaborators for the SVP. It's sort of our short-term goal. So.
Lovely. Thank you so much.
Okay, Rachel. Thank you.